Hey everyone, welcome back. So we're going to pick up where we left off with going over our asthma medications used in pregnancies. So it's important to note how we classify the safety of medications in pregnancy. It would be typically unethical to enroll pregnant patients into investigational studies. So we see it a lot of times in drug literature that a majority of our data comes from pregnancy registries. So those are basically databases that will have pregnant patients report what medications they took while pregnant or breastfeeding. And then they can retrospectively look at the mother or trans man or the baby to see any early or long-term effects, and then follow them throughout to see if any of the medications they took are having any long-term effects. So most of the data to support the use of a medication in pregnancy and or lactation is based off of real-time use, as these patients are not included in clinical trials. So we have all the same typical classes of asthma medications used in our non-pregnant patients. There's just some more details as to what is recommended in pregnancy. So to start with our short-acting beta agonists, we have terbutaline, albuterol, levolbuterol, and pirbuterol. The main one you're going to be seeing is albuterol, as you all may be experienced. So this is preferred in terms of asthma medications in pregnancy. And there was no increase in major birth defects, preterm delivery, low birth weight, in SABA exposed pregnancies. Now moving on to our long-acting beta agonists, we have a similar recommendation as compared to the SABAs. So for our LABAs, we have formoterol and salmeterol. So same here, there was no birth defects noted in LABA-exposed pregnancies. Next, we have our inhaled corticosteroids, or ICS. So we have a few options. We have budesonide, beclomethasone, fluticasone, and mometasone. These are all preferred / first line with no increased major birth defects noted. However, it's important to see here that dexamethasone and betamethasone are not recommended. Next, we move to our combination agents, so our inhaled corticosteroids and our LABAs. So I've listed some of the preferred combinations. We have budesonide formoterol, fluticasone salmeterol, and mometasone formoterol. Similarly, as we've already gone over these drug classes, there was no increase in the birth defects. Next, we have our leukotriene modifiers. So these are montelukast or zafirlukast. If the patient is already on this medication before they become pregnant, it is okay to continue. However, if they are wanting to start them while the patient is pregnant, that's where it becomes variable in terms of the data. So it might become more of a risk versus benefit. So if they're already on it and they're continued during pregnancy, that's okay. To start new is a questionable portion of that. And then we move to our anticholinergic. So for this, we have ipratropium. If you can see here on the right side of the table, there is no available human safety data. So this is where it comes in with the registries. So typically that just means that there is not enough data to support or discourage their use. And it might come down to risk versus benefit in severe cases, as we typically see our anticholinergics used in severe asthma attacks, I should say. So the next three sections are all to be used with caution, specifically monoclonal antibodies, having a warning to not recommend them in pregnancy. We have our oral corticosteroids, so methylprednisolone and prednisone. There's variable data there to support or discourage their use. Similarly, it is not entirely recommended, but it isn't contraindicated either. We need to consider the patient as a whole and their risk of being without steroids versus the possible complications of them taking it. So as you can see here, some of the complications noted include preterm delivery, low birth weight, preeclampsia, and gestational diabetes. So while these do seem to be occurring more frequently in patients that took oral corticosteroids, There may have been some underlying characteristics or confounding variables that also led to these. So it can't be said for sure that those are a direct cause, but it is definitely something to consider in patients being started on steroids for their asthma. So like I've mentioned with a few of these medications is risk versus benefit. So, when thinking about the patient and them going untreated versus them taking an inhaler or a medication that could potentially harm them, it was found that treatment with inhalers or oral medications are safer than untreated asthma. If a patient is on an inhaled corticosteroid, we do not want to stop that during pregnancy. It's also important to note that with all of our medications, we like to use a stepwise approach. So, if somebody's having an increase or an exacerbation, we want to increase their therapy, that's fine, but we don't need to jump to the most severe step, which I'll get to in a minute. But remembering to start with the lowest effective dose and increasing from there. It's typically seen that a higher dose will have a higher likelihood of having some of these side effects or birth complications. Lastly, it's important to acknowledge that there's a low priority for step down during pregnancy. So let's say a patient is on triple therapy for their asthma and they seem to be doing really well. Their asthma seems very controlled. Maybe in a non-pregnant patient, this is when we can see about taking some of those medications away. However, that is not a priority in pregnancy. We do not want to put them into the risk of having an exacerbation. So if they are maintained and they're on a regimen, we're not going to focus on step down therapy until postpartum. So now moving on to how we actually manage asthma. So the main guideline used for asthma are the GINA guidelines. They were last updated in 2022, and they are cited at the end of this handout for your guys' reference. So they do have a section for pregnancy specifically. However, the recommendations for asthma management in terms of inhaler recommendations and stepwise approaches are not different from pregnant to non-pregnant patients. It's very important that you guys can all recognize steps 1 through 4 listed below and in the picture underneath, and then acknowledging which track the patient is on and choosing their stepwise therapy based on if they're on track 1 or track 2. The main difference we're going to see between track 1 and track 2 is that track 1 is using a LABA initially and track 2 is using a SABA initially. So to orient you to this table, so we start with their presenting symptoms. So starting with the first row, we see that if a patient is having infrequent asthma symptoms, so that's defined as less than 2 times a month with no risk factors for exacerbations. Depending on if they're already on one of these 2 tracks or not, you can go with as needed low dose ICS plus a formoterol, being our LABA, or you can do a low dose ICS taken whenever the patient's as needed SABA is used. And then moving on to the next step. So if they're having asthma symptoms or need their reliever at least 2 times a month or more, the track 1 recommendation is the same. So as needed low dose ICS and formoterol. For track 2, they would then move to having a daily low dose inhaled corticosteroid with the PRN SABA. Moving on to from there, so if the patient is experiencing troublesome asthma symptoms most days, this is defined by 4 to 5 days a week, or if they find that they're waking up from their asthma at least 1 time a week or more, we then need to move for track 1, we need to move their as needed low dose ICS and formoterol to then a daily maintenance and an additional as needed. So what that would look like is letting the patient know that every day you're going to use your low dose ICS and formoterol as you would any other maintenance medications. If you start to feel troublesome asthma symptoms or shortness of breath, you can then use the same inhaler for an as needed controller medication. For track 2, they would then move to using a low dose ICS and LABA, so our ICS and formoterol, for example, with the additional PRN SABA. Lastly, if their initial asthma presentation is severely uncontrolled, or if they're in an acute exacerbation, For track 1, we would go from the low dose, then to the medium dose ICS formoterol as daily maintenance, and then that same PRN as reliever therapy. So like I explained before, this is when we consider adding in those oral corticosteroids and doing the risk versus benefit. For track 2, we could consider similarly going from a low dose to a medium or a high dose ICS LABA with the same PRN SABA. So this picture here was taken right from the GINA guidelines. I think it's, I know people like to look at tables or charts differently to help understand it. So this table kind of outlines the different tracks, outlining start here if, depending on their initial treatment, and then doing that stepwise approach. So whichever picture works better for you, just make sure you are familiar with steps 1 through 4, and then track 1 and 2, and being able to assess where the patient needs to move throughout that. So now moving on to acute exacerbations, we can manage our pregnant patients the same with a little more attention to the use of steroids as mentioned above. So let's say a patient comes in, they're in an acute exacerbation. Typically, they're going to be given oxygen. They'll be given a nebulizer to use. It's found that, patients in exacerbation, having them try to use an inhaler, it's very challenging. So they might just give them a nebulizer treatment and then ventilation only if needed. And as discussed before with the systemic glucocorticoids or systemic steroids, we want to reserve those for patients with a poor response to the initial inhaled treatments. And then there's listed some of those same risk factors of using steroids in pregnancy. Patient monitoring is also very important, and the guideline recommends the following monitoring. So for a monthly monitoring plan, we want a written action plan. So that's going to look like the patient meeting with their pharmacist or with their physician to create a written action plan. So if you remember, it's that chart that has like the green light, yellow light, red light. So if they wake up, they should be using their peak flow meter daily, and that's before they use any of their inhalers or oral medications. Based on that peak flow meter, it kind of directs them how they should assess their asthma for that day. So we want to make sure they're getting monthly updated written action plans. And then they should be getting monthly FEV1s from their provider, monthly FeNO tests, and using telehealth as needed. Moving now to patient education. I know I already kind of touched on this, but it's very important that we educate on correct inhaler use. I'm sure you've all seen, or maybe you will see as you continue into your rotations, that a lot of times patients are increased on their inhalers or have add-on therapy, when really the first problem was that they aren't using their inhaler correct at all. And so if they're not using it correctly, no medication is getting into their lungs. At that point, are they really even on therapy? And then we're just adding more and more medication burden to them. So we want to make sure we're doing correct inhaler use and assessment at each refill, and seeing where we can jump in for an intervention. Moving now to the actual labor and delivery part of pregnancy. So labor and delivery increases the risk of exacerbations. There is a 10% of acute attacks are seen during labor. So of course, similarly with our exacerbations, we want to try inhaled medications first, and then moving to IV steroids as needed. It's important to note that in these cases, fentanyl would be an appropriate choice to use, but we want to avoid the use of morphine, meperidine, and other opioids, as those can actually increase histamine and thus increase bronchospasm and worsen the exacerbations during labor and delivery. We also see an increased risk of C-section in our asthma patients. It's not clear why, but that additionally results in increase in postpartum asthma attacks. If IV steroids are being used, it's important that we monitor the baby for hypoglycemia for the first 24 hours. And lastly, moving to breastfeeding. Breastfeeding and medication is as equally important consideration to look at compared to pregnancy. because we want to look at the concentration of medications that will be passed from the mother to the baby during breastfeeding through breast milk. So it has the same recommendations as pregnancy in regards to medications, but it's important to note that when it comes to oral steroids, a dose greater than 10 mg per kg will result in about 25% of the mother's serum concentration being passed through breast milk. So it's best if they can wait 4 hours after taking their steroid dose, if they happen to be on steroids, to breastfeed the child. All right, that is all we have for asthma. In the next video, we will start our hypertension segment. Thank you.